Hey guys, welcome back. The topic that we're going to study now is valvular aortic regurgitation. So let us have a look at why this topic is asked primarily. You can see that because there's an incompetent aortic valve, so the blood is going to leak from the aorta to the left ventricle, and this is going to cause a development of an early diastolic murmur. But when the blood rushes back into the chamber of the left ventricle, it will also go and strike against the mitral valve. If I just zoom in the image, you will notice that it is going to strike the anterior leaflet of the mitral valve and can set up vibrations in the anterior leaflet of the mitral valve. These vibrations which are set up here will result in development of a second murmur, which is called as a mid-diastolic murmur. And the technical name for this mid-diastolic murmur is what is called as Austin-Flint murmur. This is one of the primary reasons why this topic is asked in the exam. So I have handled the problem right away. I'll be drawing the line diagram for the murmur subsequently, but I mainly want you to remember that the problem is in the aortic valve. Agreed. But the vibrations are being set up in the mitral valve, and that's the point that he wants you to remember, that in Austin-Flint, it is the mitral valve leaflet, mainly the anterior mitral valve leaflet, that is involved, and the vibrations that are responsible for it. Now let's look at why the disease would be developing. So we will focus on the causes, and the first cause to be remembered would be a bicuspid aortic valve. When I say that, the query from a lot of young doctors is that you said the same thing for valvular aortic stenosis also. The logic is that if the door will not open properly, it will also not close properly. So bicuspid aortic valve can not only contribute to a stenotic lesion, but it can contribute to regurgitation as well. Cause number 2 is so dangerous that if, God forbid, it develops in a patient, it can contribute to death in the next 24 hours. I'm going to give you a worst case scenario. The patient of mine has developed an acute bacterial endocarditis involving the aortic valve. The large volume of blood that's going to leak from the aorta to the left ventricle will overwhelm the left ventricle, contributing to acute decompensated congestive heart failure. The pulmonary edema is going to be severe, and in spite of our best efforts, if urgent surgery is not done in acute aortic regurgitation, most patients do not survive beyond 24 hours in spite of the medication and the best medical support that we can provide to them. And what did this infective endocarditis cause? It caused a perforation in one of the valve cusps. So therefore, this cusp would be incompetent. It will not be able to do its job. The blood from the aorta will leak back into the LV and will overwhelm the left ventricle. Cause number 3 is more from the Indian perspective, rheumatic heart disease. You very well know that isolated aortic valve involvements are not same with rheumatic. It's mainly gonna coexist with a mitral valve involvement. Therefore, the query that comes to me most of the time is that rheumatic heart disease contributes to stenotic lesions. Then how is it gonna contribute to aortic regurgitation? See, the logic is initially there will definitely be thickening of the cusps of the valves, but subsequently there will also be fibrosis. This fibrosis will contribute to shortening of the valve cusps. Now, if you read the statement carefully, when I say shortening of the valve cusps per se, so their coaptation will not be proper. I mean, if they're shorter, there will definitely be a gap present between which blood can leak. Cause number 4 will be myxomatous degeneration of the valve. The last time I used this terminology before you, myxomatous degeneration of the valve, was for mitral valve prolapse. So just like MVP can occur due to myxomatous degeneration, even aortic regurgitation can occur. From the exam perspective, point number 5 and point number 6 are of paramount importance. I agree that syphilis has now become rare. Cardiovascular syphilis will also be rare. But per se, due to historical reasons, they want to see that are you aware that syphilis can not only cause damage to the thoracic aorta, it can not only contribute to a aortic aneurysm in the thoracic aorta, but it can even cause involvement of the root of the aorta. It can even cause scarring of the aortic valve, and because of the scarring, it has become incompetent, because of which the blood can leak. Cause number 6 is ankylosing spondylitis. The patient would be HLA-B27 positive and will be having sacroiliitis with classical radiological findings, subsequently a bamboo spine. This person will later on also develop costochondritis and costochondral stiffness. So the message is that the orthopedic aspects of ankylosing spondylitis are well read by us. So he will deliberately ask you the cardiovascular association of ankylosing spondylitis, and that's going to be the topic that we're studying. So do remember the statement: cardiovascular association of ankylosing spondylitis is aortic regurgitation. For point number 7, 8, 9, 10 that I'll discuss with you, the problem is not in the valve cusps. The problem is not in the chordae tendineae. The problem is with respect to the aortic root per se. There is a aortic root dilatation that is occurring, and because of this there will be a dilatation of the annulus. So per se there's no shortening of the cusp. It is the annulus getting dilated which is contributing to aortic regurgitation. So let's have reasons for it. One of the important reasons would be simply inflammation in the root of the aorta, aortitis. So he can ask you what is the reason behind development of this aortitis. Then your answer would be Takayasu. You see, Takayasu can not only contribute to involvement of the left subclavian artery and can cause unequal BP between left and right arm. It can even cause renal artery stenosis. It can even cause aortitis as well, and subsequently aortic regurgitation. Point number 8 is easier to understand: aortic dissection. You see, aortic dissection can travel in a retrograde direction, so it can contribute to, if it will travel antegradely, it will definitely involve the arch of the aorta. It will involve even the internal carotid artery. Neurological manifestations will start happening. But if the tear will extend retrogradely, no big deal, that it can contribute to not only a coronary artery dissection, but it can even contribute to aortic root dilatation and aortic regurgitation as well. One of the very important causes for aortic dissection, in fact this is itself a MCQ, what causes aortic dissection? Majority of cases it is uncontrolled hypertension. So today I'm teaching you that not only hypertension will cause a aortic dissection, but it can even cause a aortic root dilatation if it is uncontrolled, and therefore AR will occur in the patient. Point number 10 and 11 are unlikely to be asked in the exam because they are easy to remember. Marfan syndrome can cause or be associated with aortic dissection, mitral valve prolapse, mitral regurgitation, and AR as well. Point number 11 will be a degenerative disease of blood vessels, that is cystic medial necrosis. So out of these 11 causes, though all of them are important obviously, but 5 and 6 definitely I would like you to remember. And once we have remembered the causes here, then our objective would be to discuss two important definitions. First and foremost would be, what would be the echocardiographic criteria to identify severe aortic regurgitation? Because whenever they ask you a valvular disease per se, they always love to ask about the severity of the disease. So the first important feature will be that there is a substantial amount of blood leaking back from the into the left ventricle from the aorta. So, I mean, how much? The quantification is what is important. So, regurgitant volume, if it is in excess of 60 ml per beat, and that's very substantial because you see stroke volume is 80 ml, 60 ml is leaking back. The same definition is what I have also described for severity of mitral regurgitation as well. Instead of saying regurgitant volume and the mathematical value, he can say regurgitant fraction. So just remember, more than 50% out of 80 ml blood that went out of the heart, 40 ml has come back into the heart. The third point that I'll write is very peculiar because you don't read it on a regular basis. Diastolic flow reversal. Now, the word diastolic flow reversal you can read multiple times, but diastolic flow reversal in the descending part of thoracic aorta. You see, in aortic regurgitation, there is a to and fro movement of the blood. Blood goes in forward direction because of the incompetent valve or aortic root dilatation. Some leaks back also. So I said, because the blood is going back into the heart, which does not happen in you and me, there is a diastolic flow reversal in descending thoracic aorta, and this event cannot occur in a normal individual. For progressive aortic regurgitation, the first feature to be remembered would be that the ejection fraction of the heart will be reduced. Normal is definitely 65% or more. This is less than 50%. Then would be left ventricular end systolic dimension and left ventricle end diastolic dimension. Mark my words there. I did not say end systolic volume. I did not say end diastolic volume. I said end systolic dimension and end diastolic dimension. The values here are more than 50 mm and more than 65 mm. Now, what is the importance of this is, the importance is that diastolic dimension is much more than the systolic dimension. Why? Because the blood is leaking back into the left ventricular cavity from the aorta. So you don't need to remember these mathematical values. The simple point I'm trying to highlight is the chamber of the left ventricle is dilated. Now comes two aspects. If it's gonna be acute, if it's gonna happen very fast, then the left ventricle has absolutely no chances. The left ventricle will decompensate, patient will go into ADCHF. But if it's gonna be chronic, slow, gradual onset manifestations, then there could be development of left ventricular hypertrophy. So the main message that I'm gonna give you is, if it's acute aortic regurgitation, we have is a development of left ventricular failure. In chronic, we rather have is a eccentric hypertrophy of the heart. Let me just explain this on this line diagram. Let us assume that there is a substantial volume of blood leaking back from the aorta into the left ventricle. So it's gonna cause gross distension of the LV. The left ventricle will fail. The pressure will be transmitted to the left atria, so left atria will also get dilated, and the same pressure will be transmitted to the lungs also. So there will be a severe pulmonary edema occurring in a patient. The learning point is, in acute aortic regurgitation, left ventricle really does not have a chance. The person goes into acute decompensated congestive heart failure. But if I reduce the magnitude of blood, so see what I'm doing here is, let us assume only 2 ml, 3 ml, 4 ml, 5 ml, little amount of blood is leaking back into the heart due to any of the reasons that we have discussed. If the amount of blood that will come back here will be relatively lesser, it is going to contribute to stretching of the wall of the left ventricle. The stretching of the wall of the left ventricle will then cause an increase in the force of contraction of the left ventricle. Guys, what I'm teaching you here is a law of physiology. In the first diagram that I drew before you, there was no physiology that was operating because everything happened very fast. But if less amount of blood will leak back in, Frank-Starling law can definitely come into the picture. And you very well know meaning of the word Frank-Starling law is that if you stretch the myocardium, it responds by contracting more forcefully. So whatever extra volume of blood came in, it could be 1 ml, it could be 2, it could be 5 ml. But because it will add power, therefore when you're gonna check out the pulse of this patient, you will notice a fast rising pulse. In aortic stenosis, I have described a slow rising pulse, pulsus parvus attardus. I have described the word anacrotic pulse, but here I'm saying fast rise thanks to the increased power which is coming in with this little amount of blood that is leaking back into the heart. But after that, you will notice a fast fall also. Why? Because there is incompetence of the valve. So you are having two features, the fast rise due to Frank-Starling law, fast fall due to incompetence. I repeat again, fast rise due to Frank-Starling law, fast fall because of the incompetence of the valve, and therefore you always get this characteristic feature that is Corrigan's pulse, or is also called as water hammer pulse, or is also called as a collapsing pulse. This is a feature that you encounter in the chronic format of aortic regurgitation. Another problem that will occur in this person will be that because the blood is leaking back into the heart, especially with respect to the left ventricle, everything that I'm talking at the moment is with respect to the left ventricle. Therefore, preload of the left ventricle of this patient will be increased. I have put plus signs to here say because there is gonna be more blood coming into the heart, so therefore preload of the left ventricle is definitely more, and because the peripheral perfusion will also be hampered because blood is going back into the heart, so there will be peripheral vasoconstriction in these patients, which will explain the afterload will also be increased. I repeat the statement, why afterload is increased? Because blood went back into the heart, no? So ultimate peripheral perfusion is hampered, so the RAS system kicks in and afterload gets increased, and if both preload and afterload of any chamber of the heart is increased, it will dramatically increase the oxygen requirement of the heart, and this explains why chest pain is present even in aortic regurgitation. We get chest pain in aortic stenosis, understandable, because there is a concentric hypertrophy of the heart, the demand of the heart is more, supply is normal, so mismatch between demand and supply, you get chest pain. But here it is increased oxygen requirement of the chamber of the heart. Or if you find this complicated to remember, let me simplify by saying that coronary blood flow is maximum during diastole. The blood has to go into the coronary arteries during diastole, but what is happening in this chap? The blood, instead of going into the coronaries, a large volume of it or a substantial volume of it is leaking back into the chamber of the left ventricle. You see, this blood that is coming back into the LV is wasted. Why wasted? Because this was supposed to go into the coronary arteries of the patient. So therefore, coronary blood flow, I'm using a short form, coronary blood flow is reduced in aortic regurgitation. Why? Because this blood was supposed to go into the coronaries. It is rather a waste that instead of going into coronaries, it is going back into the chamber of the LV. This decreased coronary blood flow will again explain why angina will be also experienced in these patients, and for management of this angina, when you will give nitrates, the response will be limited. Why I'm saying limited is because traditionally nitrates are very, very good for angina because they dilate the arteries, but those dilated arteries should be having some blood also, no? Here the blood is rather being diverted back into the ventricular chamber, so therefore the nitrates will they will definitely be used, but the response that we get with nitrates, normally we get a very excellent response to chest pain when you give a nitrate infusion. In this particular case will be limited. So though that's more of a clinical feature, but I've just highlighted the fact here that angina can be seen in these patients. The simple way to remember is reduced coronary blood flow, and if the coronary blood flow is itself lesser, then nitrates will have a limited response in the medical management of these patients. In the long run, what's going to now happen is that these chaps will be developing a eccentric hypertrophy of the heart. So I have reshaped the heart, but you will notice that I have tried to also show that this is a eccentric hypertrophy. What is the difference between concentric and eccentric is that in concentric hypertrophy, the cavity of the ventricle remains same dimension. It is muscles that increase. In concentric hypertrophy, it is only the muscles that increase. So therefore, the heart will look bigger, but it is muscles that are more. Cavity size is the same. Whereas in this diagram, you are noticing that because the little amount of blood is coming back into the heart again and again and again, so heart is getting used to this extra blood that it has to accommodate for a long period of time. Therefore, the chamber of the left ventricle will increase here in dimension. This is eccentric hypertrophy. This is an important concept which has to be understood. So I'll try to explain this again. In aortic stenosis, you have a concentric hypertrophy. The entire cavity size does not change. The cavity size remains the same. It is only muscles that are more. But in eccentric hypertrophy, it is an enlarged left ventricle. The cavity size is more, and this has adapted due to this little amount of blood that was continuously leaking back on a, I would say, on a long-term basis into the chamber. And therefore, in this diagram, I have highlighted with respect to both acute variety and chronic variety of aortic regurgitation, the fluid dynamics which are to be understood. The summary point is heart failure develops in acute AR. In chronic, the heart adjusts to this load, and therefore one of the largest size heart, obviously a large hearts can be seen in dilated cardiomyopathy. Cardiomyopathy anyway has a large heart, but then a valvular lesion where a heart size can be up to 1 kilogram. I'm quoting Harrison here. A valvular condition where heart size can be going up to 1 kg is aortic regurgitation of the chronic variety. Otherwise, enlarged heart can obviously be seen in hypertrophic obstructive cardiomyopathy also, but there the fundamental disease process is different. Here we are talking about valvular disease per se, which contributes to an enlarged heart. Let's now look at clinical features that you encounter in a patient of aortic regurgitation. This is a slowly developing process. The latency period for development of chronic variety can be as long as 10 to 15 years. But once the manifestations will occur, interventions should be done within the first year of development of symptoms, because if you intervene late, irreversible damage would have occurred. I said two things. The disease is slowly progressive, as is understood by the name. But once the symptoms are occurring, intervention has to be swift. So let's look at a couple of symptoms that this person will be describing, and initial two symptoms that I will write will be very non-specific. This chap says, I have shown to various doctors and they were not able to identify my cardiac condition. Why? Because it's not the fault of the doctor. His symptoms were very non-specific. One of the non-specific symptom was that whenever I lie supine, I used to have an uncomfortable sensation in my chest. So I said, okay, you were having an uncomfortable sensation in your chest. Was it chest pain? So he says, no, sir, it was not chest pain. So I thought, okay, I mean, if it's not chest pain, it might have been palpitations. So I said, do you have pounding sensation in your chest, like your heart is beating very fast? So he says, no, sir. So I was thinking to myself, I mean, what is this guy talking about? You see, the point is, the textbook says that because every time there's going to be leakage of blood back into the heart, whatever be the volume, it could be very less. But after all, it's an abnormal cardiac event. So there might be some fluttering sensation in the chest of this patient. We are not talking about palpitations. It is simply leakage of blood back into the heart, which causes chest discomfort in these patients. And initially, because the symptom is very non-specific, so the disease will not be picked up. The second problem in these patients is because there's a to and a fro movement of blood in the body. You see, blood goes out of the heart, then some part of it comes back into the heart. So there might even be a head pounding sensation. So he might say that I used to perceive a bit of headache, and because I complained of this pounding sensation, so some physician had even prescribed me medication for migraine. But all of this is initially very non-specific. Once the cardiac decompensation will occur, that's when the left ventricular end diastolic pressures will start increasing, that the pulmonary edema component will come in, and that is when these patients will come to medical attention. Like when he lies in the bed at night, he will be having breathlessness. He says, whenever I lie down, I have to put pillows behind my back, otherwise I feel so breathless, I feel so suffocated, orthopnea. Then will definitely be angina component coming up. The reasons I told you were many, but one that was very clear was that because the blood is coming back into the chamber of the heart, it should be going into the coronary arteries during diastole. So coronary blood flow is lesser, and subsequently as the disease will progress, even the right side of the heart can be involved. That's mainly neglected cases, and then you can be having ankle edema as well. So the symptoms are traditional of any cardiac case related to left side of the heart. Let's now look at a couple of examination findings of these patients, and one of the very characteristic feature that you will notice will be jarring of the body. I mean, the textbook says, because there's a to and fro movement of blood, so the textbook says jarring of the body. And even when you examine the neck of this patient, there will be abrupt distension and collapse of the major arteries. Now, when I say abrupt distension and collapse of the arteries, you very well are understanding that I'm talking about a couple of clinical signs which are found in this condition. So let's have a look at these classical names, because these are not only important from a final year exam perspective, but he can ask this in a competitive exam as well. So the first one that would come up is called as D. Musset sign. This would be head bobbing. So I'm not saying head nodding, right? I'm saying head bobbing. So this is gonna be primarily the to and the fro movement that I was describing. Then you would also be able to appreciate pulsations in the uvula of this patient, and the clinical sign, the name of it is called as Muller sign. Most of the time in final year exams, they would love to ask you names, but even in competitive exams, it's always a good idea to be ready with these names also. Or otherwise, if he makes it easier for you, if he mentions himself that there is pulsations in the liver of the patient, pulsations in the spleen of the patient, pulsations in the pupil of the patient, then he will make things very, very easier for you. After these two signs, I will also check for whether there is any evidence of any connective tissue disorders, because like in Marfan syndrome, we are having arachnodactyly. That means that the fingers of these patients would be very long. So while doing a general physical examination, it's always a good idea to also look for evidence of any other findings that can be seen related to the causes that I mentioned before you. If the person is suffering from ankylosing spondylitis, HLA-B27 positive condition, then I will simply ask him to bend forward and touch his knees. Because of the sacroiliitis component, these patients will have difficulty in bending forward. The test that I'll be doing by putting markings on the back of this patient is called as modified Schober's test. I have described this test in a description of ankylosing spondylitis in rheumatology subsequently. You would have also read about it in orthopedics as well. So please refer to the rheumatology section for this one in the lecture of ankylosing spondylitis per se. For the fifth manifestation of this patient, we are going to evaluate the Corrigan's pulse in the patient. The alternative name is water hammer pulse. and also referred to as a collapsing pulse. Now I have already written the word collapsing pulse, so this time I thought I'll write the word Corrigan, because water hammer and collapsing are easy to pick up, so I used an alternative term. This is a fast rising, fast falling pulse. What I'm simply gonna do here is, though this is obviously not a practical class, I will be first obliterating the radial artery of the patient, and after obliterating the radial artery, I will be elevating the arm of the patient. So there are two things that we are doing, and I'll just zoom into the image to explain this also. First, you try to obliterate the radial artery. You will obviously ask the patient, is there any problem with your shoulder joint? He will obviously say, because let me say he's a young person, he says no problem with my shoulder joint, no pain, so I am gonna suddenly elevate the arm. Now in a normal individual, if you raise the arm, it's gonna definitely contribute. I mean, you are raising the arm above the level of the head, but it's not that the blood is gonna leak back into the chamber of the heart. But in this person, you will notice that when the physician will elevate the arm, the blood will leak back into the chamber of the left ventricle and will contribute to distension of the left ventricle. Distension of the left ventricle will contribute to the heart to operate on Frank-Starling law, and therefore it will contract with more force. The subsequent contraction will be more forceful, so therefore the pulse will definitely be appreciated. Though initially you had obliterated the pulse, but you will be able to feel that pulse. Why? Because there is an operation of a Frank-Starling law in this case, because the blood is leaking back into the chamber of the LV, which is not gonna happen in a normal individual. So the message is that the next impulse that comes in this case, the initial impulse that you were able to feel was obliterated by the force of your fingers, but the next impulse will definitely be forceful. This is Corrigan's pulse. It is also called as a fast rising and a fast falling pulse. Point number 6 and 7 will be valid for findings with respect to the femoral artery of the patient. So I'm going to describe Trube sign before you. This is going to be pistol shot sounds which will be heard over the femoral artery of the person. Very classical terminology. I mean, if he is gonna write all these terms, then I think that the question will become relatively much more easier. But still, because this is classical information, so I am investing time into it. Now, once I have heard these pistol shot sounds, what I'm gonna do next is I will try to compress over the artery with my stethoscope. You see, anyway, there's to and fro movement of blood occurring in this person, and moreover, I am trying to compress the femoral artery of this patient with my stethoscope. This is definitely going to contribute to development of a murmur, and this murmur that I'm able to appreciate over the femoral artery of the patient is what is called as Durozius sign. I'll just put in the data here. Durozius sign would be compression over the femoral artery with your stethoscope, because of which you are able to appreciate a murmur. For point number 8, I'll show you an image. All I'm going to do is that I will gently press on the nail bed of this patient just at the edge where the nail is finishing, and you will be able to notice blanching and then redness occurring at the nail where the nail is originating. I'll just repeat the fact once again. What I said was that in this particular patient, first I'm gonna put pressure at where the nail is ending, right? And then I'll be able to see two things. In fact, at the moment in the image, you can definitely notice some redness present. So there will be blanching. That area will become white and then it will become red. So blanching at the nail bed followed by a redness that would be present, and this is what is technically called as Quincke's sign. From the exam perspective, I can say that if the signs are mentioned, it will become relatively easier for you to pick this up, and because obviously I can't write as fast as I can speak, so I'll just mention the data here for your convenience, that at the root of the nail is what you are going to see two things. That is, one, there would be blanching present, and then there would be flushing alternatively occurring, or I can write the word flushing and pallor alternatively occurring with corresponding to the beats of the heart. Point number 9, however, is very interesting. So from point number 1 to 8, the pulsations part is easier to pick up, but for 9, definitely if you're noting down, leave a line here and listen to my inputs here. In valvular aortic regurgitation, what happens is that the systolic blood pressure of the patient is definitely increased. The reason why the systolic blood pressure is increased is because the stroke volume of the heart is increased thanks to the Frank-Starling law that I was explaining to you. The diastolic blood pressure of the patient is, however, on the lower side. Why diastolic blood pressure is lesser is because the blood is leaking back into the heart, so the aortic recoil will be lesser. I repeat the fact once again. Reason for increase of systolic blood pressure, increase of stroke volume thanks to Frank-Starling law. Aortic recoil is lesser because less blood is going into the aorta, majority part went back into the heart of the person. So therefore, the pulse pressure will definitely be increased. In fact, when you will record the blood pressure of these patients, it's a possibility that systolic blood pressure might be 160 and diastolic blood pressure will be 0. It is not that the diastolic blood pressure is 0. It might be that the Korotkov sounds in these patients might be perceived right till the very end. When you check the blood pressure of a normal person, you notice the fact that when Korotkov sounds will disappear, that's when the diastolic blood pressure is present. But in this particular case, the Korotkov sounds would be present right till the end because of the abnormal hemodynamics. So therefore, whenever you are recording diastolic blood pressure of a aortic regurgitation patient, do not wait for the Korotkov sounds to disappear. Rather, check out when they have become muffled. Important point I said, do not wait for the Korotkov sounds to disappear. Just wait for them to become muffled. That's phase 4 of Korotkov sounds, and that is the diastolic blood pressure of these patients. Though if it's going to come right till the end, I can even write a value of 0, but this is not a true value. But in the exam, you can say in which condition can you be having a diastolic blood pressure to be perceived as 0. It's not 0. Diastolic blood pressure to be perceived as 0. So conditions where this can be happening can be arteriovenous malformation, if a person is having an arteriovenous fistula, or the current condition valvular aortic regurgitation. The next point is again more important from the blood pressure perspective. If I check the blood pressure of you and me at the moment, I'm talking about normal at the moment. If I check blood pressure of you and me in the upper limb, the blood pressure will be something in the range of about 120/80 or lesser. In the lower limb, because of gravity, the way I am sitting on a chair at the moment, if you are going to record my BP in my legs by putting the BP cuff in the middle of my thigh, hear the Korotkov sounds over my popliteal artery, due to gravity, the systolic blood pressure will be relatively more. So one, I have said for a normal individual, the difference between the upper limb and the lower limb blood pressure is less than 20 millimeter of mercury. However, in a person who's having the valvular lesion that is being discussed at the moment, that is aortic regurgitation, this difference that I mentioned in a normal person is less than 20, can be more than 20 millimeters of mercury, and this is what is technically called as Hill sign. And I'll just put this at point number 9 of the discussion also. Hill sign basically means that there is an exaggeration of a normal physiological difference in the BP in the upper limb and the lower limb. In a normal person like you and me, the BP in the legs is more. The way I am sitting, if I'm lying, then this is not valid. The way I'm sitting on a chair at the moment, the effect of gravity would come in, so the systolic blood pressure in the legs is higher. This difference of 20 in a normal person is exaggerated in patients of aortic regurgitation, so we get a Hill sign. Now, before we proceed forwards, I'll draw another line diagram before you. This is not related to aortic regurgitation, but is related to a condition by the name of coarctation of aorta. See what happens. There is a narrowing at the starting point of the descending aorta of the patient. This is the subclavian artery subsequently. Because less blood will go to the legs. When I check the BP of this particular person in the lower limb, the BP will be turning out to be lesser. Remember what I was teaching you for you and me, it is going to be elevated, but in this chap, with coarctation of aorta, because there's a physical narrowing, the lower limb BP will be less. Let's look at what will happen to the BP in the upper limb of the patient. The formula for blood pressure is cardiac output multiplied by peripheral resistance. So if the peripheral resistance will increase, the blood pressure will also increase. So you can notice that in the diagram that I've drawn before you at the moment, the findings are totally changed. In a normal human being, BP is more in the legs, but in this particular chap, BP is more in the upper limb. This is itself a question. Reversed situation, BP more in the upper limb as compared to lower limb is seen in coarctation of aorta. But if it is going to be exaggeration, this is opposite of what happens physiologically. But if you're going to be having an exaggeration of physiology, that's what I highlighted here, difference more than 20, then this would be a valvular aortic regurgitation in a patient. So these are a couple of important features that you need to remember. Subsequent findings that I'll explain to you will be from the cardiovascular perspective. I'm going to have a look at the apex beat of this patient and then auscultate also. The apex beat will be heaving in character primarily because of the left ventricular hypertrophy, but that is of the eccentric variety. The apex beat will also be displaced. Normal apex beat is 2 cm medial to the mid-clavicular line in this case because the heart is becoming relatively bigger. So apex beat might be even in the 6th intercostal space. Because of the turbulence in the heart, you might even be able to appreciate a thrill. Like in aortic stenosis, I have mentioned a thrill which will radiate to the carotids. Here the thrill will be mainly appreciated at the left lower sternal border, and this thrill will be appreciated in the phase of diastole because after all aortic regurgitation is a diastolic phenomenon. But the next statement is important and must be listened with care. When the blood will come back into the heart, the subsequent contraction will also be with more force. So there is a possibility that in the suprasternal notch of the patient, earlier I was talking about a thrill that you are going to be perceiving at the left lower sternal border. But now I'm saying that when the left ventricle will contract with force, even that is going to contribute to development of turbulence and a thrill. This thrill can be perceived in the suprasternal notch of the patient and will be a systolic thrill. Why this is important from the exam perspective is because we all know that aortic regurgitation operates in diastole, and in an MCQ when you will write systolic thrill, we will think it is wrong. But you need to understand, because we are talking about chronic variety, the problem is in diastole, agreed, but then Frank-Starling law and the other allied aspects that I've highlighted before you, the eccentric hypertrophy that I've highlighted before you, makes it easier to understand that during the contraction phase also a systolic thrill can be appreciated in these patients. When it comes to the second heart sound, the A2 component will be very soft because there is leakage of blood, so the turbulence that is occurring is primarily because of the murmur. The aortic valve closure will however be of lesser intensity. You might be able to hear an ejection click. This ejection click is heard only in those cases where there is a bicuspid aortic valve. You see, bicuspid aortic valve is difficult to open, and problems with closure also. If it's difficult to open, it causes the ejection click, a loud one, and the blood will leak back into the heart also. Since in chronic AR, there will also be a left atrial hypertrophy. So left atrial hypertrophy always contributes to fourth heart sound in these patients. And then we will have a look at what happens to the murmurs in these patients. The murmur that will be heard will be mainly in the phase of diastole, the moment the aortic valve will close, and this will be a decrescendo murmur. The term that will be used to describe is early diastolic murmur, and this is because of the turbulence which is shown at the moment. But ultimately this jet of blood will go and strike the mitral valve also. Do remember the fact that this mitral valve that is being struck at the moment and the vibrations that will occur of the mitral valve is occurring during the phase of diastole. I want to say a term, systolic anterior movement of the mitral valve, SAM. This is discussed in the app subsequently. Systolic anterior movement of the mitral valve is a feature that is seen in hypertrophic obstructive cardiomyopathy. But what I am saying at the moment is there is a diastolic event in which the mitral valve is involved, and it is the anterior leaflet which usually gets involved in this case. The vibrations are going to contribute to a development of a mid diastolic murmur. This that I'm showing in a dotted fashion is the technical representation of what I started this discussion with. I would rate this as the most important point of this discussion. The reason why you get a Austin Flint murmur is due to the vibrations in which leaflet. It is the anterior leaflet, but when it is happening during the phase of diastole, and this can be easily mixed up with what I'm saying next, systolic anterior movement of the mitral valve. Both are fundamentally different concepts. So I would like you to note it down on a small stick-on pad, stick it on somewhere so that you can read this statement again and again so that this becomes permanent memory for you. This is not anterior leaflet that I'm saying. Systolic anterior movement of the mitral valve is an echocardiographic criteria for one of the commonest cardiomyopathies, HOCM. But what I have described at the moment is that there would be a diastolic event that will strike the mitral valve, putting it into vibrations, and it is the anterior leaflet. I'll just mark the anterior leaflet here. It's the anterior leaflet which is going to be oscillating here and producing this turbulence, which is mid diastolic murmur. So you are having more technical information here. Austin Flint murmur is a feature of aortic regurgitation. Agreed. It will definitely be a diastolic murmur. It will definitely be mid diastolic. But what is producing it? It is not the leakage of blood across the aortic valve. The topic we are studying is aortic valve disease, right? But the current problem is not the originating from the leakage of blood across the aortic valve. The problem is occurring because of the vibrations in the anterior leaflet of the mitral valve. So that's the core information to be understood. Next information that is safe for this murmur aspect is to be listened with lot of care. Though I have given you the concept already, but lot of guys listen to this casually and end up messing in the MCQ. I said blood will leak back in the heart. There is the eccentric hypertrophy also. So the heart will contract with more force thanks to Frank-Starling law. When heart will contract with more force, it may even contribute to ejection systolic murmur. You see, ejection systolic murmur is what I had described in the topic of aortic stenosis. But at the moment, even in aortic regurgitation of the chronic variety, you might be having is a ejection systolic murmur. I repeat my fact. Ejection systolic murmur, aortic stenosis, no issues. Everybody understands. Turbulence because blood is going out of the heart. Here, what is happening is the eccentric hypertrophy of the heart and the Frank-Starling law is responsible for this turbulence. So don't be shocked if they talk about systolic murmurs in a case of aortic regurgitation. I agree. Traditionally, we have early diastolic and mid diastolic murmur. Reasons explained. Early diastolic is because of the blood leaking across the aortic valve. Austin Flint is due to vibrations in the mitral valve, and the subsequent part when the heart will contract, extra blood present, Frank-Starling law coming in, eccentric hypertrophy explains the ejection systolic murmur. If you get this slide right, what I have explained at the moment, you are done with this topic in a sense that most of the time in the exam, they just want to see that you understand the hemodynamics of operation of chronic variety of aortic regurgitation. Now I will mention some more clinical signs before you. I had mentioned 11 till now. So there are 3 more which are to be remembered from the exam perspective. Very classical names because after all there's going to be turbulence everywhere. I said the whole body of the patient is jarring. So there could even be pulsations in the spleen. And the person who described it first time in his honor, I mean this is what is called as Gerhardt sign. We don't read about pulsatile spleen on a regular basis. So that's why this definitely has its own importance. As far as pulsatile liver is concerned, you will notice that in this app, I have spoken about pulsatile liver for tricuspid stenosis, tricuspid regurgitation, and the current topic, aortic regurgitation. The technical aspects of pulsatile liver or TS and TR are discussed in the respective segment. So I would like you to focus it there. And this is what is called as Rosenbach sign. A Rosenbach sign is seen in Graves' disease also. So I will explain to you when you read the word Rosenbach in Graves, but at the moment for aortic regurgitation, it's a pulsatile liver. And then I had mentioned, if you were listening to me carefully, the word pulsations in the pupil. I mean, I'm not talking about hippus that you see with aconite poisoning. I'm talking about pulsations in the pupil, and this is what is called as Landolfi sign. So classical names coming up here. I mean, after all, since we are discussing them, so it's always a good idea to at least try and remember them once. I'll be also mentioning a couple of other allied terms since I mentioned about troop sign with respect to pistol shot sounds. I'm also mentioning regarding troop space that you read in GI in a per abdominal examination. This is related to the spleen. I mean, whenever we have a spleen enlargement, the troop space will change its resonant note. And then we also have is a Rosenbach sign with Graves' disease. This I think you guys can comment here also. Because you do read about this in endocrinology, and this would be eyelid tremor. So two facts to be remembered. I'll repeat them for record purposes. Rosenbach sign in aortic regurgitation is pulsations of the liver, but Rosenbach in Graves would be eyelid tremors perceived in the patient. That's primarily because of sympathomimetic stimulation related to excess of T3 and T4. We shall now be talking regarding workup of these patients of aortic regurgitation. The first investigation would be a ECG, and this will be showing left axis deviation as well as evidence of left ventricular enlargement. The diagnostic criteria for left ventricular enlargement would be that the depth of the S wave in V1 and the height of the R wave either in V5 or in V6 should be more than 35 millimeter. Though for chamber enlargement, it is also recommended that we should do a echocardiography. If I will be doing a chest X-ray in this person, then not only the cardiothoracic ratio will be increased, there would be a cardiomegaly, the CT ratio will be more than 0.5, but the left ventricular apex will always be having an inferolateral displacement. Whenever right ventricle becomes bigger, we have a superior displacement of the apex. Whenever left ventricle is large, it is an inferolateral displacement. And to confirm the diagnosis, I'll be anyway doing an echocardiography. I have already told you the echocardiographic criteria of severe aortic regurgitation, where I told you that the volume of blood that could be leaking back could be as much as 60 ml per beat, or it could be a fraction also described. The regurgitant fraction could be more than 50%. Once we have identified the condition, we will look at what are the steps to be taken for management of these patients. So we will first talk about how would I manage a patient of acute decompensated congestive heart failure due to the acute variety of aortic regurgitation. So I will be putting this patient on loop diuretics, that is IV furosemide, and I will also try to reduce the preload of the heart as well as the afterload by starting the patient on sodium nitroprusside. Traditionally, we read about sodium nitroprusside for hypertensive crisis. At the moment, I'm speaking about sodium nitroprusside, which is a very good vasodilator. So it will improve the functioning of the heart. It will reduce the load on the heart. Intra-aortic balloon pump is contraindicated in these patients. Why? Because if intra-aortic balloon pump will be deployed, you know that in intra-aortic balloon pumping, the balloon is deployed during the phase of diastole. And this is anyway a diastolic lesion. So when you deploy a balloon in the aorta during the phase of diastole, it will worsen the aortic regurgitation of the patient. So intra-aortic balloon pump is contraindicated in aortic dissection. That's understandable. Aorta, there's a tear present, you use a balloon, that will worsen the tear. But it will also worsen aortic regurgitation lesion because the balloon is deployed in diastole. That's the main concept. The word is intra-aortic balloon counterpulsation. Counterpulsation means balloon is deployed during the phase of diastole to increase coronary blood flow. But instead of giving you benefit, it might cause you a disadvantage because it will cause more blood to go back into the chamber, and already the left ventricle is decompensated. Similarly, beta blockers are not to be used. You very well know beta blockers are used in chronic congestive heart failure, but beta blockers are always contraindicated in acute decompensated congestive heart failure. If you gonna be using beta blockers here, they will slow down the heart. Heart will get more time to relax. If you give more time for the heart to relax, it will receive more blood. Already the poor fellow is suffering from lot of stress. So we would like to spare the heart from two things, IABP and beta blockers, and surgery should be done in these patients in the first 24 hours. Otherwise, these patients usually do not survive. Let us now look at what will we be doing for management of a person of chronic aortic regurgitation. Since a large number of these patients can be having concomitant hypertension, that hypertension could either be due to age, or I can also say that when you look at the formula for blood pressure, it is heart rate multiplied by stroke volume multiplied by peripheral resistance. If you have an eccentric hypertrophy of the heart, if you have a heart operating on Frank-Starling law, the stroke volume of the heart will be increased. Because the stroke volume is increased, the blood pressure will also be increased. So even if they don't have a coexistent hypertension due to old age, it might still be developing due to the valvular lesion itself. Remember, in the chronic variety of aortic regurgitation, because of the eccentric hypertrophy, because of Frank-Starling law coming into picture, blood pressure will definitely be elevated. That will worsen the angina. So systolic blood pressure is definitely to be kept under check. It should be kept less than 140 millimeters of mercury. Those are anyway standard guidelines for hypertension. For management of the chest pain of these patients, definitely nitrates are the weapon that you have, though I have explained to you already that nitrates may not be very beneficial. The word is very beneficial. That means at least some benefit will be there, but considering the kind of response that you get in chronic stable angina, the dramatic change in the appearance of the patient will not be seen in this case. Then he can quiz you regarding treatment of cardiovascular syphilis. In fact, this is itself a question. Cardiovascular syphilis, you will be using penicillin, that is 2.4 million units. This would be given intramuscularly, and you would be giving 3 shots to the patient on a weekly basis. So this is itself a question, that what is the treatment for cardiovascular syphilis. As far as beta blockers are concerned, when I was a student your age, we used to study beta blockers are never ever to be used in both acute and chronic. He said beta blockers may be used, so I'm writing the word may. That is, as far as the usage of beta blockers is concerned, when I was a student your age, we used to study beta blockers are not to be used either in acute, neither in chronic. But the current edition of Harrison says that beta blockers may be used. The disadvantage is that they will relax the heart, they'll decrease the heart rate, and therefore diastole duration will increase. What I mean by relaxing the heart, because that's how I'll explain to the patient, the diastole duration will increase. So when diastolic duration will increase, it will cause more filling of blood. That will rather worsen the case, but at the same time it will also reduce oxygen consumption of the heart. So they have found that there is a disadvantage, but there is an advantage also. So that's why they've said that these drugs can definitely be used. And the main aspect would be that we will be going in for a aortic valve replacement. In MCQs, it will be written as AVR. Aortic valve replacement is indicated in all cases of severe variety of aortic regurgitation if they are symptomatic. You see, I already explained to you latency period is fairly long. So therefore, if the person will become symptomatic, we definitely have to go in for aortic valve replacement. You will notice that in the earlier part of the discussion, I also used another term, progressive aortic regurgitation. I'll just come back to that slide for progressive aortic regurgitation and show you the features there. The features were like this, that we had talked about systolic and the diastolic dimensions of the heart. Now what I'm trying to say is that if a person is suffering from a progressive aortic regurgitation, he will deteriorate into a development of severe aortic regurgitation. So the current guidelines are that if a person is documented to be suffering from the progressive variety, even if he is asymptomatic, we would still recommend this particular patient to go in for a aortic valve replacement. So there are two indications for a AVR. One is anyway a symptomatic chap with severe variety of aortic regurgitation. I mean, he has earned his surgery. But the point is, since we are capable of doing this procedure, and obviously the intraoperative mortality, the postoperative complications have reduced with improvements in techniques, he says currently, even if you identify somebody with progressive AR, even if he's asymptomatic, he can be advised to go in for surgery to increase his longevity or to increase the quality of life. Because if you do not intervene once the diagnosis has been done, the chances of death of these patients will be substantially high, and the heart will never ever go back to its normal size. As far as the details of Osterfeld murmur are concerned, I've already highlighted them before you. And I want to add an additional point here by saying that the early diastolic murmur that you encounter in patients of AR, this would be relatively better appreciated when the patient is sitting up and is leaning forward. This is just like in mitral stenosis, they ask you that how would you appreciate the murmur better. So your answer is you turn the patient to his left lateral decubitus position and the heart comes closer to the chest wall. So mitral stenosis murmur is best appreciated left lateral decubitus. Similarly, in aortic regurgitation, it is sitting up and leaning forwards is the best position for appreciating the murmur, and that's all based on fluid dynamics. So these are the details that I would like you to remember for this topic, guys. It definitely took a while to explain the topic to you, but I think it will be worth the effort, because knowledge, as I say, is always power. That's the biggest power that you have, because patient is gonna pay you for the cerebral power that you have. So keep learning, because this is not that you are learning passively just because you have to clear an exam. This is because you also have to become economically productive, and all this knowledge will make you economically productive. So that's one more motivation and one more reason why you should be studying on a regular basis. Thank you so much for hearing me out.